Obesity, especially in women after menopause, creates a profoundly altered hormonal landscape, one that silently but powerfully accelerates the risk of several devastating cancers. Among the most lethal are hormone-driven malignancies, postmenopausal breast cancer, ovarian cancer, and endometrial, uterine cancer. These diseases are no longer limited to genetic or age-related risk. They are increasingly tied to the hormonal chaos produced by excess fat tissue. And yet, despite decades of evidence, this connection is still undercommunicated in clinical settings, underrepresented in cancer prevention strategies, and underacknowledged in public discourse. At the heart of the problem is the role of adipose tissue as an active endocrine organ. In obesity, particularly central, visceral obesity, fat cells don't merely store energy. They secrete a cocktail of biologically active hormones, enzymes, and inflammatory cytokines. In postmenopausal women, one of the most dangerous outputs is estrone, a form of estrogen that is produced in large quantities by the enzyme aromatase, which converts adrenal androgens into estrogens in fat tissue. With the ovaries no longer the primary source of estrogen after menopause, adipose tissue becomes the dominant driver of systemic estrogen levels, often at pathological levels in obese women. Elevated estrogen promotes continuous stimulation of estrogen-sensitive tissues like the breast endothelium and uterine lining. Without the counterbalancing effects of progesterone, which typically declines more steeply postmenopause, this unopposed estrogen leads to unchecked cellular proliferation, creating fertile ground for mutations, DNA damage, and ultimately, cancer. This is not theoretical. Postmenopausal women with obesity face up to twice the risk of developing breast cancer and up to 4 times the risk for endometrial cancer compared to lean counterparts. Endometrial cancer is perhaps the most directly and dramatically influenced by obesity. Roughly 60% of endometrial cancer cases are attributable to excess weight. The chronic hyperestrogenic state produced by fat tissue causes persistent stimulation of the endometrial lining, often leading to abnormal cell growth, hyperplasia, and eventual malignant transformation. It is no coincidence that the rise in endometrial cancer rates mirrors the trajectory of the obesity epidemic, especially in high-income countries. Breast cancer also follows this trend. While obesity is associated with a reduced risk of premenopausal breast cancer, likely due to altered ovulatory patterns, it becomes a major risk enhancer after menopause, when estrogen production shifts from the ovaries to adipose tissue. The most common form of breast cancer, estrogen receptor positive, ER+, is particularly sensitive to this hormonal environment. Worse, obese women with breast cancer often present at later stages, with larger tumors and more aggressive biology. They are also more likely to have comorbidities that complicate treatment and face reduced survival rates compared to lean patients with the same diagnosis. Ovarian cancer, while less directly linked to estrogen, is influenced by obesity in subtler but equally dangerous ways. Obesity can disrupt hypothalamic pituitary ovarian signaling, contribute to insulin resistance and chronic inflammation, and impair immune surveillance, factors that collectively support tumor development and progression in the ovaries. While the data are less consistent, a pattern is emerging. Obese women diagnosed with ovarian cancer tend to fare worse, with lower survival and higher recurrence rates. Despite all of this, cancer prevention messaging rarely emphasizes weight management as a tool for hormonal balance. Hormone replacement therapy, HRT, reproductive history, and genetic factors dominate risk assessments, while obesity, one of the few modifiable drivers of estrogen excess, is too often ignored. This silence is dangerous. Women are not being told that excess weight in midlife is not just a cosmetic or metabolic concern. It's an endocrine disruptor that could fuel hormone-sensitive cancers with devastating consequences. Even oncologists often fail to incorporate weight counseling into survivorship plans. Women treated for ER+ breast cancer, for instance, are often prescribed aromatase inhibitors to block estrogen production, yet little is done to address the primary source of postmenopausal estrogen in obese patients, their own adipose tissue. This represents a fundamental misalignment in care. Drugs are prescribed to fight estrogen chemically, while the biological source of estrogen is left untouched. The situation is even more dire for underserved populations. Obesity rates are higher among low-income and minority women, and access to cancer screening, early detection, and preventive care is often limited. This intersection of risk leads to stark disparities in outcomes. Black women, for example, are more likely to be diagnosed with late-stage hormone-sensitive cancers and have lower survival, in part due to both higher obesity rates and systemic healthcare barriers. Failing to address the hormonal impact of obesity in these communities is both a clinical oversight and an issue of justice. The endocrine disruptions caused by obesity aren't limited to hormone-sensitive cancers either. They likely affect treatment response across cancer types. Obesity alters the hormonal milieu in ways that can interfere with targeted therapies, reduce the effectiveness of chemotherapy, and worsen the side effect profile of endocrine treatments. Despite this, few clinical trials stratify participants by weight or adjust hormonal intervention strategies based on BMI or adiposity levels. This is not a minor oversight. It's a structural flaw in how we approach cancer prevention and treatment. If we want to lower cancer incidence, especially among aging female populations, we must stop treating obesity as a background variable and start recognizing it as a central driver of hormonal carcinogenesis. A new paradigm is urgently needed, one where women are informed, early and often, that fat tissue is a potent source of estrogen postmenopause. That weight gain in midlife is not benign. That maintaining a healthy body composition is not just about heart disease or diabetes, but about avoiding some of the most painful and deadly cancers they may face. Obesity is an endocrine disruptor, a silent hormone factory feeding some of the most common cancers in women. Until we integrate this truth into every level of cancer care and public health messaging, we will continue to allow a preventable driver of disease to grow unchecked. The consequences will be measured not just in rates, but in lives lost to cancers that didn't have to happen.